Today we're going to talk about optimizing hematocrit in bloodless medicine, the science and the practice. Anemia is extremely common. It's so common that I refer to it as a normalized deviation. That is, it's often accepted as normal because it's seen so frequently and it's accepted as relatively harmless. Transfusion has been seen as the default management strategy and is a low-risk, high-benefit intervention despite robust clinical evidence that in fact it's high risk and often with minimal or no benefit, frequently harm in fact, as we know. The evidence shows that anemia is a significant modifiable or correctable risk factor for increased perioperative morbidity and mortality, and we should diagnose it and treat it before elective surgery, indeed before any surgery, and indeed anemia should be identified, diagnosed, and treated even in patients who aren't expected to come to the hospital. So how common is anemia globally? This was a study that was published in 2013 showing the total global anemia prevalence by age. And as you can see, the risk of anemia varies with age, highest in the very young and the very old. And anemia prevalence has decreased somewhat over the last 20 or 30 years. But importantly, there is a gender disparity. As you can see from this highlighted graph, the prevalence of anemia is much higher in women between the ages of menarche and about age 70. If you look globally, about a third of the world's population is anemic. That's 2.3 billion people around the globe. And when we look specifically at the surgical patient population, around 30 or 40% of elective surgery patients have anemia or iron deficiency or both. And there's a much higher prevalence in patients who have certain comorbidities like chronic kidney disease, chronic heart failure, inflammatory bowel disease and other inflammatory processes, diabetes, and surgeries for conditions that cause chronic blood loss. The easiest example to think of is patients with colorectal cancer. Now we know that preoperative anemia and postoperative outcomes have a correlation, and the correlation is not a good one. This is a study from the American College of Surgeons National Quality Improvement Surgical Database, looking at 250,000 patients over the age of 18 undergoing non-cardiac major surgery, but excluding trauma patients. Similar to the data I just showed you, 30% of the patients were anemic, and even mild anemia, which they defined as a hemoglobin between 10 and 12 grams per deciliter, 100 to 120 grams per liter in women, 10 to 13 grams per deciliter in men, was independently associated with a significant increase in 30-day adjusted mortality and a 30% plus increase in morbidity. The increased morbidity and mortality with anemia was present, but perioperative transfusion did not seem to mitigate or improve those morbidity and mortality outcomes. In fact, transfusion was associated with an increased additional risk of morbidity and mortality. And so the authors concluded that treatment of preoperative anemia should be strongly considered and that transfusion was the least favorable option. There are other reasons why we should care even more about anemia, that there's value in recognizing and treating anemia that goes beyond reducing the risk of transfusion and the perioperative morbidity and mortality that accompanies transfusion. We know that effective clinical management of anemia improves patient outcomes in underlying chronic medical conditions, specifically chronic heart failure, chronic kidney disease, inflammatory bowel disease, and rheumatoid diseases. Anemia can be an indicator of an undiagnosed underlying disease process. As we all know, iron deficiency is often suggestive of an occult GI malignancy or GU malignancy. And so there's real value independent of the transfusion issue in identifying people who have anemia, diagnosing the underlying cause and treating it effectively. So turning back to the surgical patient population, comprehensive patient blood management, of course, involves management of treatable anemia and optimizing the hematocrit, anemia recognition, diagnosis, and management. I'm not going to spend any time this morning talking about all of the other aspects of good comprehensive patient blood management. Of course, we've heard about some of those things over the previous lectures, but clearly, in addition to optimizing hematocrit before surgery, we want to maintain the hemoglobin and hematocrit during and after surgery. So meticulous procedural hemostasis, management of anticoagulant antiplatelet agents, antifibrinolytic drugs, intraoperative cell salvage, and reducing phlebotomy blood loss for laboratory testing. These are all aspects of maintaining the hematocrit, but optimizing hematocrit before the surgical procedure means anemia recognition, diagnosis, and management. So before we can treat anemia, we need to know what is causing the anemia. We want the problem identified so that we can target the therapy specific to the underlying cause of anemia. And in general surgical patients, the most common underlying treatable causes of anemia are those seen on this slide, with iron deficiency by far and away the most common cause worldwide. But we certainly encounter patients who have anemia for these other reasons: vitamin B12 and folate deficiency, chronic kidney disease and chronic heart failure, inflammatory bowel disease. Although, as we'll see, many of these other underlying causes of anemia do involve iron uptake and iron metabolism. Certainly, we encounter surgical oncology patients, and I've listed on this slide some specific causes of anemia that are seen in patients with malignancy. Of course, marrow involvement by tumor, chemotherapy-associated anemia, cancer-induced anemia that has an etiology that's involved with the production of inflammatory cytokines and genetic regulatory aspects of erythropoiesis. But once again, iron deficiency anemia, both absolute iron deficiency and so-called functional iron deficiency, which is frequently, outside of chemotherapy-associated anemia, the predominant mechanism of anemia in patients with cancer who don't also have marrow involvement. So let's turn now to building an effective preoperative anemia management program. It should be designed to establish an infrastructure for delivering the care. That can be building upon an infusion clinic that already exists in the hospital, treating patients in the office with therapies, as we'll talk about, like intravenous iron, or building a freestanding anemia clinic in your facility. There's a need to develop a mechanism to screen at-risk elective surgical patients for anemia. We'll speak more about that in a moment. Strategies to identify the common causes of anemia, which we've just spoken about, to treat anemia in order to optimize the preoperative hematocrit hemoglobin, and to identify patients with primary marrow pathology or less treatable forms of anemia or serious comorbidities as a cause of their anemia, so they might be referred back to the appropriate specialist or referred to their primary care provider. Who should be screened for preoperative anemia? Well, ideally, all patients undergoing surgery should be screened for anemia, because this is an opportunity to identify patients in the community who have pre-existing anemia independent of their cause for surgery that may benefit from having that anemia identified and treated. But it may not be practical or cost effective to treat every patient who's coming to your facility for surgery. So if not all patients, then we should at a minimum screen the at-risk patients. And I've defined what I think are the at-risk patients for perioperative anemia. Procedures with a potential for significant blood loss, patients undergoing cancer surgery, patients with comorbidities who are at risk for anemia, like chronic heart failure, chronic kidney disease, or inflammatory disease processes, and patients who are at risk because of their underlying health condition for chronic blood loss and are therefore likely to have iron deficiency. And I want to emphasize on this slide and the next several slides, as we'll explore this in a little bit greater detail, is that we should use a hemoglobin of 130 grams per liter, 13 grams per deciliter, or a hematocrit of around 39% as the threshold hemoglobin and hematocrit in both males and females for addressing underlying anemia. And I'd like to explore that in a little bit greater detail. As we're all probably aware, the World Health Organization defines anemia thresholds differently in men and in women. In non-pregnant women and girls over the age of 15, WHO defines anemia as less than 120 grams per liter, whereas in men, they use a higher threshold of 130 grams per liter. But I would argue that we are shortchanging the women in our patient population by using a different threshold hemoglobin and hematocrit for diagnosing anemia and treating them for preoperative anemia. This was a study that was published quite a few years ago now, the so-called osteo study, looking at the risk of transfusion in orthopedic surgery. And what we see from this is that women, regardless of hemoglobin level, are at higher risk for transfusion than are men. And at a hemoglobin of 13 grams per deciliter, women have about a 12% higher probability of transfusion than men at the same hemoglobin threshold. This is due in part because women have smaller body mass and therefore a lower blood volume, and even for a given body mass have a smaller blood volume than men. So they're actually at greater risk for exposure to transfusion at any given hemoglobin than a man is. And therefore we penalize women if we use a lower threshold for enrolling them in an anemia management program. This is a much more recent study that underscores this same risk that women experience. In this study, almost 30% of women had a hemoglobin between 120 and 120 grams per liter, and therefore would have been considered normal by the WHO criteria and not evaluated for an underlying cause of anemia. And yet, these women, compared to non-anemic women, that is, women with hemoglobin levels higher than that, were more likely to be transfused with a transfuse risk ratio of 1.5, 68.6% versus 44.5% in these women undergoing cardiac surgery. They were transfused with more units and had significantly longer hospital lengths of stay. So I hope that I have convinced you that it's important when we establish an anemia management program that we treat men and women equally, and we use a hemoglobin threshold of 130 grams per liter as our definition for anemia and the need for further evaluation of those patients. So if we now have established an indication for anemia screening, how do we go about doing that? Well, first, we need to do a laboratory workup, once again using the preoperative hemoglobin of 130 grams per liter as our threshold. If the patients are undergoing elective surgery, it's important to classify the anemia and start treatment and to postpone the surgery until anemia improvement or resolution. And therefore, as we structure our program, it's important, if we can, to identify the patients as early as possible in the journey towards their surgical procedure so that we're not forced to delay the procedure at the last moment. In patients undergoing non-elective surgery, that is, there's an urgent or emergent need to take those patients to the operating room, it's still important to classify the type of anemia and to start treatment. And then finally, for those patients who do not have a preoperative hemoglobin that's below that anemia threshold, we simply do a standard preoperative evaluation and move on to surgery. The key lab tests for anemia evaluation are shown on this slide, and I think about them in the context of two tiers. The vast majority of patients can be evaluated using the tests shown on the left-hand side of this slide. This first tier test, of course, the complete blood count. It's important to do a reticulocyte count, and if your laboratory is able to provide a test called reticulocyte hemoglobin content, that's of value because a low reticulocyte hemoglobin content is indicative of iron deficient red cell production. So it's another way of determining that a patient has iron deficient erythropoiesis. Of course, vitamin B12, in many countries, folate should also be done. In the United States, folate deficiency is so rare that we don't routinely test for folate in our patients. And of course, the tests for iron binding capacity or transferrin saturation, and ferritin, which we'll speak about more in a moment. And I always like to include creatinine because of the frequency with which we see chronic kidney disease, and an elevated creatinine gives us a clue that the underlying cause of anemia may indeed be chronic kidney disease. If those tests do not give us the answer, then we certainly can move on using the same tubes that were drawn for the first tier testing to do second tier testing. Things like thyroid stimulating hormone to look for hypothyroidism as a cause of anemia, using the direct antiglobulin test to look for hemolytic anemia as a cause for underlying anemia. But these tests are rarely needed because, as we've mentioned, the most common causes of anemia are identified using the first tier test that I mentioned. Anemia classification in surgical patients, once again, if you look at the left-hand side of the slide here, I've emphasized using a hemoglobin threshold of 130 grams per liter for both men and women. Iron tests are the key to the entry into this decision algorithm. And you can see that we've classified anemia based on ferritin levels, with a ferritin less than 30 milligrams per liter diagnostic for iron deficiency anemia. Patients who have ferritins between 30 and 100, but with a transferrin saturation less than 20%. Typically, they have an elevated C-reactive protein indicating an inflammatory state, and this is categorized as anemia of chronic inflammation with iron deficiency. And then ferritins over 100, but with a decrease in transferrin saturation less than 20%, is categorized as anemia of chronic inflammation, which is really an iron sequestration syndrome, and in a very real sense, a functional iron deficiency. And fortunately, many of these patients will respond to intravenous iron as a therapy. And of course, if the iron studies are normal, it takes us to this part of the decision algorithm, with vitamin B12 and folate as a possible cause of megaloblastic anemia. And if all of those tests are normal, at the bottom of this algorithm, looking at other causes of anemia, such as malignancy, endocrine causes, and chronic kidney disease. Well, let's turn now to iron absorption and metabolism. And in order to understand the treatment strategies for iron deficiency and functional iron deficiency, we need to understand a little bit about how iron absorption and metabolism is regulated. This slide shows the primary mechanism for the regulation of iron uptake and transport is the hepcidin ferroportin system. Each of these cells represents an iron exporting cell. It could be the duodenal enterocyte, where iron is absorbed in the GI tract. It could be macrophages or hepatocytes, where iron is stored in the body. And you can see that under a setting of low hepcidin, iron is taken into the cell, temporarily stored in a soluble form as ferritin. It's exported from the cell through a membrane transport protein called ferroportin, and iron is picked up by transferrin, the carrier protein in the plasma, and carried to the erythropoietic marrow. In the setting of inflammation, hepcidin is upregulated. Iron is taken into the cell, but hepcidin binds to ferroportin. That complex is endophagocytized, and the transport of iron out of the cell is blocked. And as a result, in the state where there's inflammation, the body is unable to absorb enteric iron, that is iron from the diet. Fortunately, intravenous iron causes an upregulation of two proteins called iron regulatory protein 1 and 2 that increases the production of this membrane transport protein, ferroportin, and basically avoids the hepcidin blockade that I just described. So what we have is hepcidin as a regulator of iron, and inflammation upregulates hepcidin and blocks iron absorption and iron transport and creates this state of iron sequestration and functional iron deficiency. I'm not going to spend any time this morning discussing the other regulators of hepcidin, but suffice it to say that in an inflammatory state, patients become functionally iron deficient, and the way that we can work around that is by the use of intravenous iron. It also informs us that oral or enteric iron is ineffective in patients with an inflammatory state, and that includes the use of oral iron immediately post-op because of the post-operative inflammatory state. Also important to recognize that many of the symptoms that we see in patients who are iron deficient are not because of the anemia itself. Iron plays other physiologic roles besides iron in hemoglobin and oxygen transport. Oxygen transfer is important. Myoglobin is an iron-containing protein. So during periods of iron deprivation, oxygen deprivation, oxymyoglobin releases its oxygen for metabolic use. And importantly, there are numerous proteins and enzymes in the body. They're iron-containing, including the proteins of cellular respiration, electron transport, and ATP production is iron-dependent. So the fatigue and the metabolic and cellular dysfunction we see in iron deficiency may well have nothing to do with the level of hemoglobin, but rather is due to the deficiency in iron itself. So the signs and symptoms of iron deficiency, the impaired myocardial function, the increased mortality, the impaired immune function, and many of the symptoms that our patients complain about are actually due to the iron deficiency rather than to the anemia. And so it's important to correct iron deficiency in patients undergoing surgery. So what are our options for iron therapy? Well, enteric iron is an option. These are some of the over-the-counter or non-prescription iron supplements that are available. They do vary in terms of how tolerable they are from the standpoint of gastrointestinal side effects. And I'll speak more about that in a moment. But it's important to remember that even in the absence of inflammation, the maximum daily enteric iron absorption is around 5 to 7 milligrams. So a patient who's has depleted iron stores, if we use oral iron as a means of iron replacement, it can take 6 months or longer to replace the iron stores, even if there is not ongoing iron loss. So iron replacement by the enteric route can be accomplished, but it is a much slower process than replacing iron intravenously. And the different oral iron supplements vary in terms of their tolerability. Any of us who have taken oral iron know that the GI side effects of oral iron administration can be significant. In this case, from this study, we see that the most commonly prescribed iron products, iron salts, such as ferrous fumarate, ferrous sulfate, and even ferrous gluconate, actually are the ones that have the worst GI side effect profile. And that on the right-hand side of the slide, you can see that ferrous glycine, and which is the way that the World Health Organization actually prefers to do iron replacement throughout the world. Iron protein succinylate, that these are better tolerated and may be better options, though they are slightly more expensive, better options for treating our patients if we're going to use oral iron replacement. But our options for iron replacement, particularly if there is a significant iron deficit or we want to correct iron deficiency quickly, involves the use of intravenous iron. And these are 6 of the intravenous iron products that are available worldwide. All of them consist of an iron core surrounded by a carbohydrate shell, that carbohydrate shell varying depending upon which intravenous iron product is used. And what's important to think about, since all these do have similar safety profiles and similar efficacy is that the amount of labile or free iron and therefore the maximum iron per dose varies between preparations. And the reason for that is if you look at this slide, iron gluconate and iron sucrose, and in this case, we're looking at two different doses, a 200 milligram dose, and in blue, a 500 milligram dose. And what we see on the y-axis is the micrograms of labile or free iron. The free iron is much higher in iron gluconate and iron sucrose. That is, the iron is much less tightly bound than it is with low molecular weight iron dextran or any of these three iron products, iron isomaltose, iron carboxymaltose, and ferromoxetol. In fact, the 200 milligram dose of iron sucrose and iron gluconate has as much free iron as the 500 milligram doses of iron isomaltose, carboxymaltose, and ferromoxetol. What that means is that the amount of free iron is the limiting factor in how much you can give as a single dose. So as a result, we limit the use, the dose of iron sucrose and iron gluconate to no more than 200 to 300 milligrams per infusion. Whereas with iron dextran, low molecular weight iron dextran, you can give total dose iron replacement with a single visit to the clinic. And 1,000 milligrams can be given safely over 1 hour. So this is a very efficient way to deliver intravenous iron to a patient with just one clinic visit or one encounter in the hospital. Ferromoxetol can be given IV push over 15 minutes with a maximum single dose of 510 milligrams. And you can see that ferric carboxymaltose and iron isomaltosite also give you an option for a much larger dose in a single encounter with the patient than do iron sucrose and iron gluconate. Calculating the required dose, the Ganzoni equation, which I've listed for you on this slide, has been around for many, many years. As an alternative, frankly, the easiest thing to do is to administer between 750 and 1,000 milligrams of IV iron, and then clinically reassess the patient to determine if a second dose is needed at some point in the future. But the Ganzoni equation can certainly be used for a more precise calculation of the total iron deficit in a patient. In terms of the safety of intravenous iron, we generally do not pre-medicate our patients before we give intravenous iron. In fact, you see more complications with the pre-medication itself than you do with the intravenous iron. When you do see side effects with intravenous iron, they're usually mild allergic type reactions with flushing, pruritus, urticaria, or rash. Hypotension, when it occurs, is due to the free iron rather than an anaphylactoid reaction. Anaphylactoid reactions are extremely rare, and the way to address hypotension during an IV iron infusion is to slow the rate of infusion or to use an iron product with less labile iron in it. And I've listed the data with regard to serious adverse drug events. Suffice it to say that intravenous iron with the newer preparations that are currently available worldwide is a very, very safe medication to administer. And I've highlighted the fact that the recent published data shows that IV iron does not increase the risk of bacterial infection, which was a concern for many years. You will often hear that from your colleagues, but the data shows that IV iron does not increase the risk of bacterial infection. So intravenous iron is our most common intervention in the management of preoperative anemia. It's less expensive than erythropoiesis stimulating agents. There are few adverse events. It's effective even in inflammation. And in patients with true iron deficiency, it's better tolerated and much faster than enteric iron replacement. Obviously, if there's adequate time, no ongoing blood loss, and the patient tolerates oral iron can be considered because of its lower cost, but it will be a much slower process to restore the patient's hemoglobin and hematocrit and replete their iron stores. Now, some patients certainly do need erythropoiesis stimulating agents in the preoperative anemia setting, and that depends both on the etiology of the underlying anemia and the time that you have to try to correct the patient's hemoglobin and hematocrit. Quite a number of years ago, back in the around 2009, there was a meta-analysis that was published by Bennett that seemed to suggest that erythropoiesis stimulating agents increased risk for cancer patients. That is, increased the risk of metastatic disease, increased the risk of recurrence, and shortened overall and disease-specific survival. However, a subsequent meta-analysis published by Glasby seemed to contradict those findings. In fact, he showed that ESAs did not significantly affect mortality or disease progression. There was some suggestion that the risk of venous thromboembolic events was increased, but the risk of VTE is probably very low, particularly with short-term preoperative use of erythropoiesis stimulating agents, and especially if we co-administer iron. And the time I have available to me this morning doesn't allow me to talk about the pathophysiology of VTE and erythropoiesis stimulating agents, but it may have something to do with a decrease in iron levels when erythropoiesis stimulating agents are used, and therefore it's very important whenever we use ESAs to co-administer intravenous iron. There were some additional studies that were done subsequent to the Glasby meta-analysis. This was a study of EPO in intense dose dense adjuvant chemotherapy for breast cancer. It was a randomized controlled trial. You can see in the blue line at the top that those patients who were treated with EPO had a hemoglobin level that was a full 2 grams per deciliter higher than those who were not treated with EPO during the course of their care. And when you look at the time to relapse by therapy and overall survival by therapy, these curves are absolutely superimposable. There was no risk in terms of the use of EPO in these patients with breast cancer, speaking to the safety of ESAs in patients who are surgical oncology patients. This is the recommended preoperative use of ESAs. Of course, these slides will be made available to everyone attending this symposium. The first bullet shows the FDA in the United States recommended labeled indication and dosage for erythropoiesis stimulating agents. But I would like to emphasize that higher doses appear safe if anemia is severe or the time to surgery is short. 80,000 units 2 days before cardiac surgery in this study showed a reduction in transfusion risk from 39% to just 17% in patients with a baseline hemoglobin of 130 grams per liter or less. And I would say that because of the risk of thrombosis in cancer patients, one should at least give consideration to thromboprophylaxis in cancer patients when high doses of erythropoiesis stimulating agents are used. This is another study showing the safety and efficacy of erythropoiesis stimulating agents. This time, a systematic review and meta-analysis, 32 randomized controlled trials, almost 5,000 patients. The conclusion of the study was that there was a significant reduction in perioperative blood transfusion. This was true for both orthopedic and cardiac surgery, and no increase in thromboembolic events. And these are the forest plots showing that transfusion risk was lower in patients who were treated with erythropoiesis stimulating agents, and no difference in thromboembolic events. I want to emphasize once again the role of intravenous iron in ESA therapy. We know from past studies that in patients with end-stage renal disease, the response to ESAs were improved when intravenous iron was given at the same time, concomitantly. In chemotherapy-associated anemia, the response to ESAs was improved with intravenous iron, and in fact, a 30% reduction in ESA dose achieved the same response if intravenous iron was given at the same time. And as I've already mentioned, a recent meta-analysis showed no increase in the risk of thrombosis and thromboembolism. Want to emphasize, once again, co-administration of IV iron when using ESA, unless the patient has an iron overload syndrome, it's best practice, it's a better way of using ESA, and it likely reduces the thrombotic risk. Well, I'd like to close with taking a look at some of the studies that address the clinical impact of anemia management, the clinical impact of optimizing patients' hemoglobin and hematocrit prior to surgery. And I'd like to begin those few slides with the PREVENT trial that was published just 2 months ago in September of this year. And I show you this study because, not because I agree with the author's conclusions, but rather because I disagree with their conclusions. And looking at the data, I think it actually supports the safety and efficacy of preoperative anemia management with intravenous iron. The authors concluded that preoperative IV iron did not reduce transfusion, though 21% of the treatment group had their anemia corrected versus just 10% of the placebo group. There were many flaws in the study design, in my opinion. I've listed some of them in the bullets here, but let's take a look at the data. This is a time course of the patient's hemoglobin levels, and you can see starting both the IV iron group in red and the placebo group in blue started with a mean hemoglobin of around 110 grams per liter. The iron group had a mean increase of 4.7 grams per liter before surgery. So they clearly responded to IV iron therapy, even though the underlying cause of anemia was not predetermined. That is, this group included patients not just with iron deficiency anemia, but anemia due to other causes as well.
Yeah, but you have changed.
The authors used an apparent, by study protocol design, an apparently very high transfusion threshold because the target hemoglobin was 95 grams per liter as judged by these data from postoperative day 2. So I would say that in the absence of a transfusion algorithm, the attending surgeons used a very liberal transfusion threshold. And importantly, the iron group had post-op hemoglobins that were significantly higher 2 months after surgery than those patients who were not treated with iron, which I think shows a clear benefit to our patients. The readmissions in the first 8 weeks for post-op complications was lower in the treatment group, and repeat admissions were considerably lower with a risk ratio of 0.54. So I think this study actually shows the benefit of preoperative anemia management with intravenous iron. It's not the only study that shows the benefit. I was a co-author on this study that was published in 2018. It was a systematic review of anemia management in reducing red cell transfusions. We looked at 13 different studies and concluded that preoperative anemia management reduces the proportion of patients transfused and the number of units transfused. And these are the forest plots with the percentage of patients transfused on the top and the number of units transfused on the bottom. It clearly favored the intervention of preoperative anemia management. And then finally, a study that Dr. Farmer shared with you yesterday. This was just very recently published by Kevin Trentino and his colleagues, looking at 544 admissions for colorectal cancer and showing that red cell transfusions per admission, hospital length of stay, and net costs were lower in patients who were managed with screening for iron deficiency and treatment. And then to conclude, I wanted to emphasize the need to follow our patients after surgery. As Shannon mentioned yesterday, a significant percentage of our patients are discharged anemic and remain anemic for many months after discharge. So we must have a post-operative anemia management protocol as well as a preoperative anemia management protocol, and consider the use of intravenous iron supplements while in hospital or post-discharge at a post-discharge visit. There are some emerging treatments for anemia. I provide these for you in the slide set for reference. I'm not going to discuss this. What I want to do is to close with my recommendations for best clinical practice. To consider pre-op anemia and iron deficiency as an indication for anemia management from the decision to operate until complete post-operative recovery. Major non-urgent surgery should be postponed to allow treatment of anemia and iron deficiency. Use a target hemoglobin of 130 grams per liter for both men and women. Consider oral iron replacement for iron deficiency when the surgery can be scheduled many weeks out from the time of diagnosis because the response to oral therapy, even when it is tolerated, is much slower than with intravenous iron. Consider IV iron to be your frontline therapy for patients who have surgery planned in less than 6 weeks or whenever an ESA is used. Adjuvant treatment should include gastrointestinal, urological, gynecological, or oncological evaluation and treatment of any underlying disease. In fact, that's part of the added value of an anemia management program is our ability to identify underlying conditions that may not have been identified by the referring physician. ESAs can be used, they're safe, and they should be used when anemia is severe, when time is short, or in underlying conditions where IV iron alone will not be effective. Target the treatment to the cause of the anemia, and also remember that it takes much more than just iron to make a red blood cell. We have to treat protein malnutrition, B12 deficiency, and folate deficiency. And with that, I will conclude my remarks.